Is this thing still on?
I think they can hear us a bit better now. Should we keep talking?
Of course. Let's say it louder for those in the back. Hi, and welcome to the Gritty Nurse Podcast, an unfiltered discussion about health and healthcare. My name is Amie Archibald-Varley,
And my name is Sara Fung.
and we are your podcast hosts.
If you're listening on Apple Podcasts, Spotify, YouTube, iHeartRadio, or any other podcast platform, don't forget to hit subscribe so you can get updates on new episodes.
If you love our podcast and our advocacy work, please go to www.grittynurse.com and click on the Support Us button. This will give you access to exclusive episodes and early releases on a monthly basis.
This will help us with the cost of running the podcast, the time and energy to put out awesome and informative episodes. And for that, we thank you and we appreciate you.
Hi, and welcome everyone this week. Thank you again for tuning in. I'm just still laughing about the fact that my mouth is burning from some Thai food that I just ate, but we're probably not going to get too much into that anyways.
But you know what? That's kind of fitting because this is a hot, spicy topic that we're going to talk about
Oh,
today.
oh, snap, Sarah.
I try.
Yeah. No, that was a good one. But yeah, so today we're actually going to talk a little bit about the formula shortage, various different feeding methods, so breast versus bottle, or fed is best, whatever the case may be. But we thought that we would, we're going to put our gritty spin on it. And I think this has actually been a long time coming. Sarah's been evading me every time I've been asking her to have this topic, but it's actually a really challenging conversation for us to have, because I think, as maternal child nurses previously, we had been taught a lot about, baby friendly initiative and, these various different things. And I think it's only as myself becoming a parent and really hearing kind of some other people's stories that, my mindset has changed in terms of, how we should really go about these conversations, how we should talk to women. And just, yeah, with Roe v. Wade, talking about abortion rights, talking about women's rights in general, I think it's just a conversation that we should have.
Yeah, and I'll tell you why I feel like this is a hot topic and why I've been evading you. I think that, I think infant feeding and breastfeeding is a very hot topic. I think it brings out a lot of strong emotions in people. And I think just historically, like if you think back to, 100 years ago, right, there weren't really any options. If a woman couldn't breastfeed, then the only other option would be a wet nurse. So having another woman breastfeed your baby. And if you couldn't do that, then you just didn't make it. Obviously there are so many different other options now, but there has also been this huge movement of really encouraging women to breastfeed to the point where they feel guilty. They feel a lot of mental distress if they can't achieve this goal. And that has never been the goal, right? It's always been, do what's best for your baby and yourself. And somewhere along the way, I think the message kind of got lost to, you have to breastfeed or else, right? At all costs. And it shouldn't be that way. It should always be a woman's choice. And it should always be us empowering women to make the best choice for them. And it's not up to us as healthcare professionals to pass judgment on what that might be.
Yeah, no, I wholeheartedly agree with you, Sarah. I couldn't have said that any better than how you've kind of laid it out. I think the biggest part, and I think it was even with myself becoming a mother, because I remember, and oh God, I feel so fucking guilty thinking about, when I would go into that patient's room and they just delivered, right? Like our goal was like, get that baby on the breast in like 5 minutes or less, right? Like essentially when we went in for our fourth postpartum check, we did the fundus. So that is the top of the uterus. We're really massaging that to, expel clots and make sure it's nice and hard. I know, way too much
Oh.
information, but essentially another part of that check is your baby check. So you're going to do your set of vitals. You're going to see how the latch is. You're going to see how, what, like you've probably already spoken to the individual, the woman, about their choices on feeding. But again, you do that attempt, you do that first try. And I just remember being like going in there and like you're like wrestling around with their breasts, they're sweaty, they just had a baby, and you're like trying to get this baby on. And I'd say, like, there's times that we were successful and there's times that you weren't. And I could just feel
Tension.
that tension, right? That tension of that patient being like, how stressed and how tired they were. But it was like, it was literally a part of our documentation. Did the baby latch within the first hour? And that's a part of the work that we were supposed to do as nurses. But it was only until I had my own children how it dawned on me that, am I doing the right thing here in terms of what I was doing, or even how I approached it, the language that was used. And I have to be honest, there's a little bit of guilt there on my part before I had kids in terms of how I handled those situations.
Yeah, and I feel the same way because I spent many years as a postpartum nurse, hours upon hours helping women breastfeed through every possible imaginable apparatus. So, for
Right.
those of you who don't know, there isn't just breast and bottle, right? So, you could feed the infant with a cup, you could use a spoon, you could use something called the lactation aid device, which is a tube that's, taped to the woman's breast. There's all kinds of contraptions when breastfeeding doesn't go exactly according to plan. And I felt a lot of pressure to be able to breastfeed and breastfeed properly because it was literally my job. I'm like, if I can't do this, it's the same as saying that I'm a fitness instructor and I can't work out. Like, I
Right.
felt like this was my existence. And I'm like, if I can't do this, then it'll be hugely embarrassing. I would feel like a failure. And my son did get readmitted for jaundice. And as soon as someone gets admitted for jaundice, it's like, okay, we got to push the feeding. We got to make sure they're feeding, right? And so I did have help from a lactation consultant, but we don't have role models, right, for breastfeeding. I mean, do you recall in your childhood watching somebody breastfeed their child? Because I don't recall ever seeing that. We have lost a lot of that, so we just, we think the baby's gonna go on, everything's gonna go perfectly, and if it doesn't, then we start to panic and we start to go down this Google, YouTube spiral, and, like as you said, Amy, you're already spinning out of control after you have a baby, especially your first baby. It's very difficult to try and figure out what you need to do at the right time.
Yeah, absolutely. And I mean, thinking about my experiences, like just answering your question, I actually don't remember really seeing other women breastfeed. And I think this is actually a cultural thing, a Western society thing, where women tended to actually hide breastfeeding. I don't, and the thing is, it still happens to this day where there's that shame where, we're taking out our breasts to feed our child and we're shamed for it when essentially that's the reason, the intention behind us breastfeeding. It's actually for to give our children or babies nutrients. And I remember going to a bathroom, hiding in a bathroom stall, breastfeeding, or you have that stupid fucking drape that's like blowing in the wind and you're trying to like put your baby under it and they're pulling it off of their faces cuz they don't want it there, and you're trying to be modest and cover up. And I think all of that kind of leads into some of the issues we have with talking about breastfeeding, feeding in general, because as a society as a whole, we're still struggling with the fact that men have hypersexualized breasts. Breasts have a function, they have a form. In that sense, where we're feeding our child, that is the function, that is the form, that is what's supposed to be happening. But I remember getting a lot of side eye, or I remember being in a restaurant actually when they used to have spring rolls downtown, and I had my twin boys, and there was that rare moment where Jordan and I actually were able to get out. And I remember one of them started going, and one starts going, the other one starts going, and I'm like, oh crap, I gotta do this. And I remember like we were in a pretty private booth area, and I remember like pulling out my breast to breastfeed and seeing people looking at me like disgust, like how dare she pull her breast out while we're eating our food. And it's just like, oh my god. And then having that moment where you go to a bathroom and you breastfeed your child, like why? It's crazy.
You brought back so many memories of all the hours I spent breastfeeding. I used to plan out ahead of time when I would go out. I'm like, where can I go feed my baby if and when I need to? I would literally plan out where I would go based on where I could feed. And it took me a while to get comfortable feeding in public, but eventually I was like, I can't just keep sitting in bathrooms anymore because this is ridiculous.
Well,
Like
unhygienic too, right?
it's it stinks in there. People are doing all kinds of things that I don't really care to know about. And it's very cultural. Like, the other thing is I went to Hong Kong shortly after my first child was born, and There are so many options in Hong Kong for breastfeeding mothers. There just aren't a lot of breastfeeding mothers. So everywhere I went, I was escorted to this really pristine, huge infant feeding room, with a TV and a microwave and everything, because I think they were so excited that someone was actually going to use it that they really wanted to make sure I knew where it was. And
Right.
everywhere I went, there was like 20 different kinds of formula in every drugstore. It's just very culturally acceptable to formula feed, which I guess kind of dovetails into our topic about, you know, formula shortage and the use of formula in general, and what we think about that as a society.
Yeah, let's talk a little bit about this whole formula shortage. I mean, I think this is something that I don't think anybody anticipated seeing or thought was going to happen. And I think let's just kind of talk about like where did this all kind of come from. So Abbott is actually like one of the largest distributors of formula products. I think they're in Michigan. They're a huge US supplier of powder infant formula, and they actually had to close their plant. So they closed their plant because this was actually back in February. They closed their plant due to reports of bacterial infections in 4 infants. And I believe you said, I think two actually had died. And others were hospitalized. And I'm going to probably say this bacteria wrong. It's the Chroncobacter Sakazaki. And the two babies, they actually died after consuming the baby formula that was manufactured by this plant. So the plant essentially was shut down. Again, this is what happens when we have these government created monopolies, right? So this one large facilities creating the most amount of formula products in the United States, distributing all over the world, and now they're shut down. Again, this is why we have problems with capitalism and these monopolies. Like again, this is why we need to do things differently.
Yeah, and I think this whole pandemic has really illustrated how delicate the whole global supply chain is for a number of different things, formula just being one of them. And I'm actually surprised that this hasn't gotten more media attention because there is a shortage in Canada as well. It's not as severe as in the States, but again, it's a woman's issue. And I feel like because it's a woman's issue, it's not getting the attention it deserves.
100%. And again, I think the other piece that was described about, the shortage and kind of what's different here between us and the States is there were import restrictions. So another reason for the intense concentration was their import controls. And it said about 98% of the formula consumed in the US was produced domestically. So again, that's kind of a part of some of the issues. But, Canadian producers, we actually their like milk and formula here is subsidized by our government. So that's why we have pretty much steered clear of the US market. But again, we're still feeling the ramifications and impact from the US because of the supply chain issues, because of import restrictions and various different things. And one of the things that we all have to recognize is the shortage is far from over. And I think we're going to see the impact to the formula shortage here as well. And again, this is where we have to talk about what we've seen in our organizations when it comes to formula, because I think this is where other women can really connect with our stories and understand how difficult it was for us to be in those places. Because I remember what it was like when we were trying to get the status of friendly, or the baby friendly initiative. And this isn't to knock the BFI initiative. It has its merits. I believe it has its place. I believe it's important. I believe that breastfeeding is important. There's the 10 steps. I'm not going to go through them because honest to God, I can't remember them. But again, I think that some of the practices that we put in place were not supportive of women.
It's a great achievement to have. It's a great thing to encourage women to breastfeed. I will say though, I don't think that women are set up for success. So in terms of hospital stays, right? They can be as short as 24 hours. What can you
Right.
really do in 24 hours besides make sure the baby's latched and that the baby hasn't lost too much weight? So I think the hospital stays are too quick. Staff are under too much pressure to do too much. So breastfeeding is something that takes time. You can't rush it. So if a nurse has, so many patients, she or he can only spend so much time with each patient. And this is something that takes time, especially if you didn't grow up with it, especially if it was your first baby, if you had any medical interventions at all that might make it more difficult. I think more training for staff too, because, as a postpartum nurse, I felt I was lucky to get some training, but there are a lot of staff out there, especially right now, that don't receive any training, especially with the shortages and, everything happening the way it is. And, just better supports at work for pumping, for having more time off work. I know that's a whole other issue in itself, but if you have to go back after several weeks, how can you really even make sure your milk supply is established? How can you even find time or the place to pump? These are all things that affect breastfeeding. And if I was in this situation right now, I would feel even more guilty that I wasn't able to breastfeed. So not only did I maybe not meet my goals in terms of infant feeding, but now I'm struggling to find formula. And this really just compounds the issue.
Yeah, no, I completely agree, and I think one story really sticks with me, and I kind of never forget this. I remember being like a labor and delivery nurse, and I think we were we were at a point where I think we just had no beds in postpartum. So the patients were delivering and they were staying with us. And again, I wouldn't say that labor and delivery nurses have minimal training in breastfeeding. Like I think the training that I received was adequate to help support. But I remember this one patient, and it was so this patient was South Asian, and I remember that, she came in with her family. And again, within that culture, family is hugely important during the birthing cycle and whatnot. I believe her mother in law was there. And I remember a nurse saying to me, "Oh my God, you have a South Asian patient. You know how hard it's going to be to get them to breastfeed. The mother in law is just going to give them the bottle, and you're going to have to sit there arguing with them about why we should breastfeed. Oh, how are you going to have to deal with this? It's going to be so annoying." And I just remember thinking to myself, like, when did we get there, right? Because one, that's racist, and
Right.
two, if that's a part of their cultural preference, why don't we have conversations? And then again, at the end of the day, the conversation, if we have it, and the choice is still that they want to provide a formula, then we provide them formula. And I actually remember speaking to that family, and I remember the mom just saying, you know, in our culture, this is what we were afraid that the baby's going to be hungry. And I said, okay, that's fine. And she's like, we'll continue to express colostrum and breast milk until the mother's milk comes in. So it wasn't even like a no that they don't intend to breastfeed or exclusively breastfeed. It was just a this is our cultural preference in terms of how we do things. But in terms of how the organization talked about it, in terms of how even that nurse's perspective of what it was, I found it very, very disturbing. And I remember feeling very guilty because I remember sitting on some of these committees, Sarah, and
Hmm.
they would talk about, we need to put bottled milk on we need to put
Lock,
it on our
lock and
order
key.
sets. We need to lock them up. We need to, if a family member wants formula, they need to have a doctor's order. And I just remember thinking to myself, like, what are we doing? What if this was something else? Like we just talked about Roe v. Wade and talked about, the slow peel back of women's rights to choose. What were we thinking when those types of conversations were going on? When we were like, oh, we're going to stop having sponsors of Johnson Johnson, when they were helping with educational resources and other things that help support nurses, because we solely didn't want to have formula, or it was a part of this specific step. It just really, I had a lot of conflict within me. And I think at the end of the day, after I had my own kids and saw how difficult it was, and just being that person in the hot seat, I was just like, if my child has something rather than nothing, I'm happy. And I think everybody's situation is so unique. It's so different. And we have to respect that. We have to respect that as individuals. And again, this whole women doing this to women, it just rubbed me the wrong way. Like, if anybody should be supportive of women, it should be other women. I just want to peel that back a little bit about even talking about, the various different feeding modalities that we had, because we talk about women as in a very gendered way, because there are patients that come into labor and delivery that have infants that are not women, that may be trans, that may be gay males, and we have to have those considerations too. And I just think that we had a very narrow focus in terms of what our outcomes, or what our outcome measures wanted to be.
Yeah, and I actually remember getting some really good advice from a colleague of mine. And, she said, you should never want to breastfeed more than your patient does. You should meet them halfway. So, you know what I mean, right? Like, I would always ask the open question I'm like, what are your plans for feeding? You tell me, right? And if they say to me, I want to breastfeed, but every time I walk in, they've just given the baby a bottle, that's telling me that they've maybe said what they think I want to hear, but really they want a bottle feed. So if you want a bottle feed, that's fine. I'm here to support your choice. I'm also here to tell you if you want to know what the benefits are of breastfeeding, right? So if the plan is I'm going to breastfeed or I'm going to bottle feed for the first week and then I'm going to breastfeed, then I would feel an obligation to say, that might be a little bit more difficult because this is where you need to establish your milk supply, blah, blah, blah. Just give them the information. But if you're finding that you're bending over backwards and your patient's actions are not demonstrating to you that they want to breastfeed when they go home, I think that's something to keep in mind as well, or vice versa. Like if a patient says, "Yeah, I'll bottle feed," but then you see them they keep trying to, breastfeed the baby, maybe just ask them like, "Whatever you want to do is okay. Just let me know so I can support you properly."
Yeah, I mean, I think the main message really is we should be taking our cues from the patients, right? Like I think I again, I think breastfeeding is a great thing to do, but at the end of the day, if the patient does not want to, then that is their choice and we should respect that. And then what we should be doing is, providing the most amount of education or resources that we have in terms of bottle feeding because there's a lot of things I learned well after about bottle feeding that I didn't know about. And I remember making my kids their bottles and like reading the package afterward, being like, oh my God, I was supposed to do X, Y, and Z, or I was supposed to use this type of water or whatever the case may be. And I was kind of astounded. But I think at the end of the day, whatever the woman decides to do that works best for her family, that works best for her, it should be their choice. But I want to kind of talk a little bit about assistive devices and assistive services. So let's talk a little bit about lactation consultants. And I'm going to pass it to you, Sarah, to maybe explain what exactly does a lactation consultant do?
Well, I was formerly a lactation consultant. So it's a designation that you have to have, and you have to have so many years of hands on experience helping mothers with breastfeeding. You have to do a certain number of hours of coursework. And then, of course, there's an exam that you have to take. So it's specialized training to assist in all different types of infant feeding situations, all different types of medical complications, either in the mother or the infant, and be able to recognize and support the mother or parent through it. So it's something that there are lactation consultants that work in hospitals. There are lactation consultants that work privately, so they operate in the community. They work independently; it's their own business. And there are lots of different other breastfeeding supports out there that may not be run by lactation consultants. They be healthcare professionals that have experience in breastfeeding. So it could be public health nursing, it could be a community health center. There's lots of different ways you can get support, but I would say the main thing is to make sure that you're working with someone that is a healthcare professional and has the right background and knowledge to be able to support you. Um, yeah, so lactation consultants, they do have extra knowledge and expertise, and I think it's a very important thing that if you do get help, that you find someone that's non-judgmental and someone that understands and will support your goals for feeding, whatever that may be.
Yeah, no, I completely agree with that. And the other piece is like, what would you say their main role is? Like I think that so I remember seeking out a lactation consultant and actually this was with my twins. So Tristan, when I would try to feed him, he would like he would start drinking and I think my like letdown response was too much and he'd like gurgle and like "Ah," and he'd like hit my boob away and so I went and saw a lactation consultant for that. And we tried all sorts of things. We tried we used a nipple shield to slow down the amount of milk. It never really happened, like worked out. So he kind of did 6 months and then I bottle fed him breast milk. But I mean, I think there's a variety of different things that they do. So maybe you can kind of tell our listeners what are some of the roles that lactation consultants have in terms of feeding.
Well, I think that the main thing is because they have that specialized training, they can help you develop an infant feeding plan. So, whether that be an in hospital feeding plan or in the community feeding plan, the main role is really to protect and support breastfeeding. And that still extends to whether you're completely breastfeeding, partially breastfeeding, you're doing a combination of both, that's fine. It's really to support safe infant feeding. And if there are issues that they see, for example, if the infant has a tongue tie or maybe you have an issue with your breast, they will often do a health assessment, even if you've had breast surgery, if you've had implants of any kind, because that can affect feeding. They can give you advice on different things you can do to increase your milk supply as well. And the other thing that lactation consultants can do is make referrals. So if for some reason you need to be referred to a pediatrician, they can do that as well. So there's a defined scope of practice, and they have to operate within that scope of practice. And most lactation consultants are nurses. There are a few that aren't, but again, they have to meet all of the experience and coursework and pass that exam.
Yeah, I mean, so we've talked about kind of like the role, the good, the good things that they do, but let's talk about a little bit about the ugly, the stereotypes that we might have heard. And I don't know if you've seen this clip from the show's called A Million Little Things, where essentially a lactation consultant had kind of a negative interaction with the mother where she felt that she was being shamed by not calling her sooner. So she had come in to see this lactation consultant and she was like, I've been having this difficulty for like 2 weeks. And the lactation consultant was like, why? Why did you wait so long to see me? And the mother was like, oh, I'm just, I'm a new mom. I'm just kind of trying to get my shit together. And I guess she was there with her friend. And in the clip, essentially, what ends up happening is her friend's like, "Shut up," and the lactation consultant was like, "Who are you talking to?" And she's like, "You. You're the only other person in the room other than my friend. Shut up." And then she kind of explains to her like how difficult motherhood is and the fact that she made this woman feel shame. So one of the things that I'd say, even when I was a labor and delivery nurse, it was kind of this running joke where we talked about, and it's really a harsh term to be honest. We called them like lactation consultant Nazis, or there were all these various different names that we had. And I remember meeting, come on, Sarah, we know we've met like one or two that were like, holy shit, this woman is hardcore. But of course, they can have a very damaging and lasting effect on the people that they work with these types of, this type of behavior. So again, like there are stereotypes. It is a stereotype, but again, I would say that, it's a stereotype that we should listen to. So if this is some of the feedback that, LCs are getting, then maybe it's feedback that they should take and actually listen to and do something about it. So again, here were some of the stereotypes I came across. So the one size fits all lactation consultant, the pushy, aggressive lactation consultant, the rude or mean lactation consultant, the annoying lactation consultant. I think we've met all of these ones. The if you're the you're not breastfeeding if you're pumping lactation consultant, the not very helpful lactation consultant, and the stuffed baby on the breast lactation consultant. But at the end of the day, I believe that there's a lot of great that they do, honestly. But
Hmm.
again, with the good comes the bad, right?
Yeah, and I think you could extend this to nurses as well. All these stereotypes could extend to nurses. But I will say lactation consultants having access to one is a very privileged thing to have. First of all, not all hospitals can afford them. So usually if there's a budgetary issue, the first thing that goes are these lactation consultant breastfeeding services, right? So only probably the hospitals that have the funding can afford them. Also, lactation consultants aren't covered to make home visits. So, usually, the type of people that can afford them are the ones that have the extra money. And let's face it, it's several $100s to get someone to come to your
Yes.
home. Maybe now with a pandemic, it's cheaper if you do the virtual option, but it's still going to cost you, right? And another thing I want to point out about the whole world of lactation consulting is it's very non diverse. I have not met too many lactation consultants who are women or people of color. I think that's something that might help a little bit if there were women that looked like the woman that they were helping. That would probably make a difference, to be honest. But it's a very non-diverse area to be in. So
Yeah.
it's just when you see someone like you mentioned the woman who is South Asian. I wonder what difference it would have made if a lactation consultant walked in who was of the same ethnicity and maybe spoke the same language as the mother-in-law. That might have made a big difference.
There's an understanding there. That's the whole aspect of representation, right? I think it's just you can have shared experiences and shared understanding and shared knowledge with someone who might be from your cultural background. Not to say that someone who's not from your cultural background shouldn't have that same type of training, but that representation is so hugely important. And I think that, for all of the things that we've said about like lactation consultants and breastfeeding, I think obviously there are certain things that people should look for in terms of a good lactation consultant, or even someone, or even, if you're going about your journey or you've just delivered your child, like what is it that you kind of want at the end of the day? And I think any care provider who does more talking than listening is probably not the best person that will help support you. And again, it should be about what you want at the end of the day. Like, what are your goals? What are the things that you desire for your feeding choices for your infant? Yeah, like I think it's also just important that the individual is prioritized. So again, you know, I had mentioned this cookie cutter approach, and we want to really move away from that and really design plans that work for individuals.
Yeah, and with selecting a lactation salt, if this is an option for you, I would go by recommendations, look up reviews online. What are this person's principles that they operate by? Because it should always be someone who empowers you, right? Not someone that makes you feel guilty or shamed for things that you did or didn't do so far in your journey. It's really about someone that's going to make you feel good about your choices, help you with where you need help, be there for if you've changed your mind, that's always okay too, and just support women and families.
Yeah, no, I agree. And I think the other piece is just, at the end of the day, it's your decision, right? I think you have to be, like you said, Sarah, you need to be more passionate than your lactation consultant. So if they're more passionate about what they're trying to do, then it's probably that whole relationship's not clicking. And again, like you said, that aspect of affordability, right? So there's a really short turnaround time in hospitals here, particularly in Canada. It's 24 to 48 hours. And I think for some midwife births, it's even less. And again, if they're not in-house, you're looking at an additional cost, and that representation may not be there in terms of, cultural preferences and those types of choices. So again, I think just at the end of the day, when I think about these conversations and I've seen some of the experiences that women have discussed, I think at the end of the day, I know it's so cliche, but fed is best. If it works best for whatever modality works best for you, your family, your lifestyle, as long as the baby is fed and they're happy, then I'm not going to shit on whatever choice that you decide to make.
I know, and I feel like with this episode, no matter what we say, we're gonna get some hate. But I will say that as someone who did breastfeed, for a long time, it is a very big commitment. So it's important to know that too, right? Like, I'm not here to tell you, "Oh, I'm so much better than everyone because I was able to breastfeed." It's not that. I want people to know the reality of what it means to exclusively breastfeed. That means literally you cannot be away from your baby at all until they finish breastfeeding. And while it is a wonderful journey, it can be very, draining, but also rewarding at the same time.
What a pun, Sarah. It could be
Oh my
very
gosh, I didn't even
draining.
mean it as a pun, but yeah, you're right.
That's hilarious. Yeah, I mean, I just think that the most important thing here, yes, there's the evidence. And again, the other piece that's really important is making sure that whatever evidence that you're being provided with, it's evidence-based, whether it's coming from your lactation consultant, whether it's you perusing the internet or, doing Dr. Google. Make sure the evidence and the information that you have is informed by, research studies, like clinical research trials, and that whatever information is being provided to you actually checks out at the end of the day. But again, it's your choice. Whatever you decide, we should be able to be there as a nurse, as a lactation consultant, whomever, caring for you, taking care of you, and making sure that your choice, above all, is selected and is respected.
Absolutely.